Rupa, I think we should start.
Warm welcome, every friend, every colleague. It is a great pleasure to welcome you all to the IBD-ENC IBD Masterclass. And today is indeed a special day. And it is special because this is the week of the World IBD Day, as we celebrate the importance of IBD with sympathy and empathy for all those patients suffering from this chronic lifelong disease. At the same time, it's Eid, and Eid Mubarak, and wishing all of you a very happy and peaceful Eid. Before we get into the academic program, we know that it's a COVID pandemic all around. In India here, we are struggling to cope, but every academic initiative actually is a breath of fresh air. Thanking you for being there, and I take this opportunity to thank our academic partners. We have Dr. Reddy's, then we have Microlabs India Limited, and we have the Takeda. So thanks to this partnership, everybody getting together in the times of the pandemic, we are ready for an academic feast. I pass over the phone and the connection, it's a virtual world, to Dr. G.N. Ramesh to kindly take over the proceedings.
Thank you very much, Dr. Rupa, and good evening to you, friends from the IBD-ENC as well as across the world. Once again, a warm welcome to the IBD-ENC Masterclass. Today, we have lined up for you a series of very exciting academic events with the theme Management Issues in Ulcerative Colitis. And Dr. Jayanti and myself will take you through the academic session till the end. And we have two exciting lectures, a very interesting, engaging case discussion, followed by the panel discussion that will follow. So without any delay, since we have promised all those interested that we will stick to time, we go on straight into the academic session. And the first part of today evening's program is a keynote address on a very relevant topic. The topic is rescue therapy for acute severe colitis and novel predictors of outcome. And to give us this talk, we have none other than Professor Simon P.L. Travis. Simon is one of the leading lights in the field of inflammatory bowel disease all over the world. Moreover, he is a very good friend of IBD in the IBD-ENC consortium, personally known to all of us. So I think to introduce him in detail may be a mere formality, but I'll go to the extent that to say that he's a wonderfully humorous person, a lovely friend, a person who's got an in-depth knowledge about whatever he's going to speak, and his lectures on ulcerative colitis, any aspect of ulcerative colitis or Crohn's disease, are very, very interesting to hear and very engaging. So, Professor Simon, without any delay, thank you very much for being with us this evening, and it is over to you for your 20-minute talk on
predictors
of rescue therapy in ulcerative colitis and acute severe ulcerative colitis and novel predictors. Over to you, Professor Simon.
Dr. G.N., thank you very much indeed, and welcome to colleagues in India, the distinguished panel, and good evening from a gloomy Oxford. I'm just going to share my screen, and I will focus primarily on prediction. What is happening tomorrow, as if we actually knew. And my thoughts go out to Indian colleagues, not only because I wish that I was in India rather than Oxford, but also because you are struggling so much with the pandemic at the moment, and this is by way of diversional therapy. So thank you to our sponsors. Thank you to IBDENC and colleagues. I start with the disclosures, which seem to increase in number as the years go by. And let's define what we're speaking about. That is the severe attack. On the right at the top, you have Sidney Truelove. And then below that, you have Leslie Witts, who's often forgotten, but he was the Regius Professor of Medicine back in the 1950s when these criteria were defined. Diarrhea 6 or more times daily with visible blood and a tachycardia or a pyrexia or anemia or an ESR more than 30 millimeters of mercury, millimeters per hour. And you've heard me say this many times because the number of criteria, in addition to a bloody stool frequency, correlate with outcome. But things are different in India. And Vineet Ahuja and colleagues at AIMS have investigated whether this the Truelove and Witts criteria apply in India, and they've removed the hemoglobin. As you can see, the criteria just bloody diarrhea, tachycardia, temperature, and a high ESR, or indeed a CRP for that matter, define the severe attack. And the way they did it was just to take patients with acute severe colitis admitted to the to AIMS according to original criteria, and they found that excluding hemoglobin didn't classify any patient as having acute severe colitis, and that probably reflects the mean hemoglobin in the Indian population. And indeed, Vineet went on to investigate whether you could dispense with clinical criteria altogether. And he took almost 100 further patients with acute severe colitis and just checked their fecal calprotectin levels. And if you've got a very high fecal calprotectin, almost 800 micrograms per gram, that had excellent diagnostic accuracy for acute severe colitis. And I make no apologies for dwelling on the definitions, because all too often patients, or sometimes their physicians, will delay admission for intensive treatment until a late stage, and we need to look at outcomes, because it's the outcomes, colectomy, hospital discharge, survival, which matter. Now, work that we did in Oxford some little while back showed that about a quarter of our patients in Oxford developed acute severe colitis. So that's a substantial number. Originally, it was thought to be only about 1 in 10, 1 in 8, but in fact, it's 1 in 4. And what's also interesting is that we went on to show that the colectomy rate in all patients with ulcerative colitis was just 12%, 12.4%. And if they were the 3/4 never admitted with acute severe colitis, the colectomy rate was only 3%, just above 3%. Whereas those admitted at least once with acute severe colitis, it's 40%. And that tells me that those patients with acute severe colitis have a worse long-term outcome. I'm talking about that 40% colectomy rate, not during that index admission with acute severe colitis, but at any stage, because of course colectomy only happens once. And the number of times admitted, guess what, your colectomy rate goes up. And the colectomy rate hasn't changed, or had not changed, for 40 years until Dan Turner did a review some almost 15 years ago. But it has perhaps now. The reason that we get concerned is that patients die. Indeed, it was the death of a young patient that with colitis that made Sidney Truelove start investigating the condition, which was poorly defined back in 1950. And the larger the volume hospital, then the lower the colectomy rate. These are Canadian data from Gil Kaplan, And it's also noted that the number of pre-operative admission days, just in the top right there, the longer the admission before colectomy, the longer time in hospital, the longer the time for physicians prevaricating before deciding about colectomy, the higher the mortality, the higher the morbidity. That's an important, this is what we're playing with, and in many hospitals, then the numbers of patients admitted with acute severe colitis are relatively few, depending on how often a consultant is on call. It may only see 1 or 2 cases a month, and therefore only be faced with a decision about colectomy 2, 3, 4 times a year. And therefore, we need better predictors of outcome. Unfortunately, help is at hand, either at diagnosis, on admission, at endoscopy, after 3 days, or on discharge. And there are new indices, which is refining the art. We developed an index which predicted the likelihood of acute severe colitis based simply on the extent of disease in CRP and hemoglobin at diagnosis. And we found that if patients had pancolitis or extensive colitis, a high CRP and a low hemoglobin at diagnosis, then somewhere between 3/4 and in validated studies, 100% went on to have acute severe colitis. These are the data validated in Cambridge and Uppsala after our development cohort in Oxford. And you can see that every patient who met those simple criteria at diagnosis went on to have an episode in Cambridge. And whilst the numbers were larger in Uppsala and the admission rate was very much lower, they still held out for prediction. But they don't seem to work in China. And we just repeated this in last year. And you can see that applying the same criteria in China, that if you look at the purple bars where all hospitals contributing, 3 hospitals contributing, then it would just less than 40% predictive value for admission with acute severe colitis. So not very good and needs to be refined. We went on and did some machine learning on our data set in Oxford, looking at all using EPR to look at all sorts of criteria and trying to capture the inflammatory burden, because it does seem that the inflammatory burden matters, and we're still not close to having a reliable, reproducible index of knowing who's going to get a bad attack. But it seems that the worse the inflammation is at diagnosis, the more likely at some time in the following 3 years you are to be admitted with acute severe colitis. So what about those patients admitted? Next thing is you want to know, are you going to call on the services of Dr. G.V. Rao and surgery? And in Oxford, we still count the number of additional true love and wits criteria. Of course, in India, if you follow the aims, you remove the hemoglobin, so you've only got 3 additional criteria rather than 4. But you can see that if you have 3 additional criteria, about 50% will go on to have a colectomy. And that's an important message. So the more severe inflammation at admission, the worse the outcome. How do you manage that? Hospitalization, steroids. In red there, if you read the paper in APT on enteral nutrition as adjunctive therapy for acute severe colitis, it seemed to improve, almost double, the responsiveness to steroids. I think that's important, and we've certainly adopted that in Oxford. So we give patients exclusive enteral nutrition if they're admitted with acute colitis. We keep their potassium up, if necessary, with intravenous fluids, and give them hydrocortisone and assess their response. We also give them thromboprophylaxis, and we do some pre-screening bloods in case biological therapy is needed. Now, these data are interesting because they relate to Dan Turner, showing that the colectomy rate, and the full line, if you like, is that big red bar there, really hasn't changed over 40 years. But as I intimated, I'll show you data which suggests that the colectomy rate has reduced in the past decade. We like to reassess patients on the third day, and we use objective criteria because it is so difficult to use clinical judgment to decide. And we use the familiar index developed 20 or even 30 years ago, the CRP of more than 45 and a stool frequency of between 3 and 8 a day on the third day of intravenous steroids predicts about 85% will come to colectomy. Or, of course, if you've got a particularly high stool frequency of more than 8 on that third day. We tried introducing the Ulcerative Colitis Index of Severity, which will be familiar to many of you. Do a flexible sigmoidoscopy on admission because you want to exclude CMV and to assess the severity. And we've shown that if you've got a UCIS of 7 or 8 out of 8, then almost everyone comes to need rescue therapy or colectomy. Although we had death as an outcome, none of our patients died. Vineet's been busy and has shown that using mucosal quantitative PCR for CMV suggests that if you've got more than 2,000 copies per milligram, then it predicts steroid failure. Not terribly accurately, and of course, mucosal quantitative PCR is not universally available. But he has looked at fecal calprotectin UCIS and reckons that if you've got a UCIS of more than 6 on admission, so 7 or 8, and a day 3 fecal calprotectin more than 1,000, these are independent predictors, and this went on to develop what is called the AIMS index. And this simple predictive score that if you've got the high fecal calprotectin and a UCIS of 7 or 8 out of 8, then the positive predictive value for needing rescue therapy is 93%, which is good and difficult to improve on that. We in Oxford have developed a different index. I'm sorry to blind you with indices, but I think it emphasizes the importance as science progresses to use an index which predicts outcome. And Jax at Sanghi and Vipin Gupta, who was at AIMS and has been spending time in the UK, demonstrated that if you could just capture the UCIS and CRP, then you could predict the outcome. So we looked at consecutive admissions, 130 odd consecutive admissions. We validated it in Queensland, and it's undergoing validation in Delhi. But essentially, if you combined these 4 points, so CRP, which was pretty high, 100 milligrams per liter, and gave you 1 point, an albumin pretty low, 25 grams per liter, and a UCIS, if it's more than 7, is 2 points, UCIS of 4 or more is 1 point. Then if you scored 4, everybody did badly and failed steroids, whereas if you scored 0, then everybody responded, which is all great. And that's in the process of submission at the moment. And if it can be validated in the Gold Coast and India, so we've got 3 continent validation. Well, that's all. That's excellent. There are other indices, and you've just published the use of machine learning. Which is, I would regard as a proof of principle, doing what we were doing, I touched on earlier at diagnosis, but this is using principal component analysis of the electronic data records. And yes, similar things coming out, albumin, CRP, hemoglobin, and whatever. And it's still got to get to the practical stage of practical index, but proof of principle, I think that's where we'll be going and having the machines do it for us. So there are other indices, and I'll just very, very briefly mention them because they all vary on a theme. But my colleagues in Melbourne have tried to remove observer from the endoscopic observer from the algorithm, and they just use fecal calprotectin and the CRP albumin ratio. They all come down to a theme that if you've got bad inflammation, you do worse, but do use an inductive measure. So what do? You've got an index, you find that it's predicting a poor outcome. Well, you've got to have a discussion with the patient at an early stage about the prospects for modifying the pattern. Is it their first presentation? Is it relapse? Is it relapse despite immunomodulators? And that's when I call on our colorectal surgeons, because they need a discussion early, not as happened last week in a hospital in the Thames Valley after 9 days of intravenous steroids. I almost fell off my chair that they thought about asking for surgery. And of course, the patient was saying thank you, but there must be an alternative. And I think that the message that I've got is that the outcomes are changing. Because whether you use we're using more anti-TNF, we still use a lot of cyclosporin in Oxford, and I know you do in India. It's cheaper, it works as well in 2 randomized controlled trials. But if you look, the purpose of this is to compare the different cohorts over time. And if you look at our original cohort from 25 years ago in the salmon pink, we had a 29% colectomy rate. Then when Lottie Dinnerson looked at it 15 years later, 25%. Crispin Court in the UCIS study, 24%. Now we're down to 15%. So it's halved in that time. And guess what's doubled? It's the use of rescue therapy, and in particular the infliximab use. But I still regard cyclosporin as effective as infliximab. And and here's looking at the outcomes. You can see that none of our patients in the original cohort 25 years ago had infliximab. A quarter did in recent years, and highly significant difference, highly significant reduction in colectomy, and that matters to patients. I'm not going to say anything about surgery, even smart surgery, but I hope your abdomen ends up looking like that with single port surgery and not like the vast laparotomy scar I saw this morning in clinic of a patient who had a colectomy elsewhere. So to conclude and keep to time, I hope, prevention is best. If you can predict the risk of acute severe colitis at diagnosis, then those are patients who you need to follow and advance therapy at an early stage. We've still got to show the evidence that makes a difference, but it makes logical sense. If you admit a patient with acute severe colitis, and many of the several hundred people on this call will have patients in hospital at this moment in time who've got acute severe colitis, then count the number of true love and Wicks criteria, because they relate to outcome. Use endoscopy and fecal calprotectin, because if you've got a high UCIS and you've got a very high fecal calprotectin, they're not going to do well. We still use the third day index. And above all, act on those criteria. Contingency planning, get the opinion of a colorectal surgeon when at a timely manner, when there's still an option for medical therapy, but patients can talk about that. Don't ask for a surgeon when it's the end of the line and they've got to operate on a steroid-saturated patient. Use infliximab if they're already on azathioprine. Use cyclosporin if they're azathioprine naive. Don't use both together. Go for colectomy, and don't duck difficult decisions. And at some stage, I might escape from this place to warmer climates. Thank you very much indeed. Back to you, Jim.
Thank you very much, Professor Simon Travis. That was brilliant. And more importantly, really stuck to time, giving a lot of concrete messages. Acute severe ulcerative colitis and surgery are very closely interlinked together, and so must it be. That's why when Professor Simon Travis was referring to getting or involving the colorectal surgeon early enough, he put a lot of emphasis on that statement. So it is but natural that no discussion on acute severe ulcerative colitis would be complete without hearing from the surgeon. And the surgeon who is going to tell us today is Dr. G.V. Rao. Well, I would say very informally, I would call him a dynamo surgeon. He's a director, one of the directors of the AIG hospitals, a pioneer of sorts for a lot of procedures, particularly things like procedures like notes. Great teacher, and I always look forward to his lectures because it's usually a high-tech lecture. And of course, one of the terrific leaders in medicine in our country. So G.V. Rao, I'm looking forward to listening from you on a topic which is again very relevant to the theme, that is acute severe colitis when medications fail or when the medical gastroenterologist meets the surgeon. Over to you, G.V.
Thank you, Rupa. Thank you, Ramesh, for the kind introduction, actually. And it's very, very difficult to follow Simon, actually. I'll share my screen, actually. The question posed to me, acute severe colitis when medications fail. Now, after Simon's lecture, now do medications fail at all? Actually, I'm surprised. Actually, there's so much of thing that is going on in the medical aspect. I'm hardly to see any medications fail in these patients. This is basically because of exponential advances that have been happening on the medical side, including artificial intelligence that was quoted by Professor Simon Travis. But at the same time, there have been a lot of parallel exponential advances that have been happening on the minimally invasive surgery, including objective evidence of vascularity using indigocyanine green for colorectal surgery, and other predictors which have helped us in a big way to improve the overall outcomes of these patients undergoing surgery. And also, we seem to understand the pathophysiology of ulcerative colitis well. And there seems to be a gray area right now between the surgeons and the endoscopists right now, surgeons and the IBD specialists. And I'll say that it's not medications failing. Maybe it is a non-response to medications that are the patients who are coming for surgery. And I'm not going to deal with acute severe colitis. I'm just going to deal with acute severe colitis medical non-responders and the complications of this, which is a potentially life-threatening complication requiring emergency surgery. The surgical surgery is either urgent in the acute severe colitis, so not responding to medical therapy, or in toxic megacolon, or emergent surgeries in perforation, uncontrolled hemorrhage for patients with MODS. Now, why not primary colectomy in these patients with acute severe colitis? Now, these patients obviously the high risk for colectomy. The overall response rate for steroids in acute severe colitis is almost 70%. We all 30% rate of colectomy in short term of the first course of therapy, as Simon has told us already. Now we have single rescue therapy or sequential rescue therapies. Sequential rescue therapy with calcineurin inhibitors followed by inhibitors or vice versa have reported success rates of only about 25 to 40%, and infliximab followed by cyclosporine is associated with some severe risk events like herpetic esophagitis, pneumonia, pancreatitis with bacteremia, and sepsis leading to death. So what is decided right now? Following failure of cyclosporine or infliximab rescue therapy, surgery is preferred. Sequential rescue immunomodulator therapy delays surgery, and cumulative immunosuppression increases the risk of sepsis. Sequential therapy may be considered on case-to-case basis only in highly specialized centers, and in current guidelines for both adult and pediatric patients do not support treating with sequential rescue therapy after the initial salvage therapy has failed. Now, how to assess the efficacy of rescue therapy? Should be assessed daily. In the event of deterioration or failure to improve, these patients should proceed for surgery. We have various factors. Simon has already dealt with this. I'm not going to this. So the poor response predictors are increasing age, thrombocytosis, and previous use of cyclosporine can predict poor response to cyclosporine rescue therapy. And the colectomy predictors are infliximab as rescue therapy, no clinical response after infliximab induction, CRP more than 10 milligrams per liter, ASC and previous treatment with cyclosporine. Patients with fulminant disease have a decreased response to infliximab than patients with milder corticosteroid refractory ulcerative colitis. Studies have formally evaluated the timing of rescue therapy failure, but commonly response at 7 days is used to declare as failure in these patients. And you can see that whenever we delay this surgery for acute severe colitis, these are associated with increased post-operative complications, both septic complications and also post-procedure complications, and also increases the hospital stay in these patients. So delayed surgery for patients with acute severe colitis, so not responded to medical therapies associated with increased risk of post-operative complications. So a decision for surgery has to be done between the gastroenterologist, surgeon, patient, and the family, as the delayed surgery can increase morbidity. Now, the outcomes related to volumes, the relationship between volumes, high volume work has been established in IBD surgery, though not specifically for acute severe colitis, but we can always extrapolate this result with increasing expertise on the laparoscopic side. Technical expertise and an established multidisciplinary approach may improve the overall outcomes of these patients. Now, what are the surgeries that we do? Either we do a restorative proctocolectomy or subtotal colectomy with ileostomy. This is done either open, laparoscopic, hand-assisted, single port, or robotic in current clinical practice. Now, patients with acute severe colitis often have risk factors for surgical complications like severe disease, poor nutritional status, high corticosteroid exposure, and hypoalbuminemia. Surgery should not be delayed to enhance nutrition or taper steroids. Venous thromboembolism prophylaxis should be continued after surgery. Colectomy can treat acute colitis by excising the diseased tissue and reduces future risk of recurrence and malignancy in this patient. Now, why do we do this? Is restorative proctocolectomy in acute severe colitis. There are some very aggressive surgeons who have shown that these can be done with minimal morbidity and mortality, and the results can be compared with patients undergoing elective procedures. And also, there's a beautiful study from Ziv who has shown that restorative proctocolectomy can be done in acute severe colitis in this patient. But the biggest drawbacks of doing a restorative proctocolectomy in ASC is that the diagnosis of UC may be incorrect, especially in case of fulminant colitis. Performing pouch on a patient taking high dose of corticosteroids is associated with increased complications. Pelvic sepsis and anastomotic leaks are more frequent. It presents problems in early postoperative period. Could be poor pouch function or pouch failure may be higher in this patient. And these aggressive techniques should be considered with very, very experienced surgeons only. And you can see that the preoperative diagnosis and the postoperative diagnosis could be very variable. So it is not necessary that you do a restorative proctocolectomy in these patients who have acute severe colitis. Just to show you, I mean, these procedures have become all these patients with complications. Now we undergo this with minimally invasive laparoscopic procedures. This is the patient undergoing, you can see the distended edematous bubble, and then the entire colon, right from the sigmoid colon onto the right colon is mobilized. Now we have very good energy sources, and we keep changing. Now we have the new energy sources combined both ultrasonic shears and bipolar energies, which decrease the amount of bleed in these patients. And you can see that at the end of the procedure, this entire specimen can be extracted to a small wound, which is the place where the ileostomy can be positioned. This is the entire specimen that is being extracted. You can see this. The entire specimen can be brought out of this small wound where the ileostomy can be positioned. Now, why is proctectomy not done in this patient? Because it increases the procedure time, and because of the edematous bubble, it increases the risk of injury to the pelvic nerve. There is a risk of bleeding, and it could negatively affect the future creation of a pouch. You can see this is very, very difficult whenever you're doing a proctectomy in these patients with acute severe colitis. Now, how do we manage these patients manage the rectal stump? Rectal stump has been a concern both because of the potential risk of having a residual disease and the possibility of a stump blowout. But the residual disease activity can be controlled with topical agents, and it is ideal that we leaving little rectum as possible may cause, especially if you leave a short rectum, it is the chances of blowout are quite high as compared to the long segment. So a short stump versus a long stump. A short stump, you divide the rectum at the level of the promontory, and in these patients, a transanal rectal drainage is advised some days to prevent any blowout. So in long stump, an initial distance sigmoid colon with the rectal stump is used, which is brought out of the mucus fistula on the anterior abdominal. Now, stump blowout is a very common complication. Now, this is usually happens because the rectum is usually thick and friable and carries the risk of perforation, and the incidence of blowout could be as high as 12%, and the incidence of blowout is very high when the stump is short. And whenever we have these patients with blowout, these patients who have increased septic complications, the morbidity is very high. So the ideal stump is a longer stump, a long stump which includes a segment of the sigmoid colon. This stump can be either closed or it can be brought out of the mucus fistula under the skin. And you can see this is how that is the segment about the peritoneal reflection. That is the rectosigmoid junction there, and we are stapling this segment well above the peritoneal reflection, including a part of the lower sigmoid. This is a long stump, and this facilitates your subsequent pouch formation. Subsequent pouch formation makes it very easier. And you can see this, the mortality and morbidity of using a short stump versus a long stump. The long stump is always better than the short stump. The incidence of complications are more in a short stump as compared to a large stump. And it's been shown that laparoscopic subtotal colectomy for acute severe colitis is a very good procedure, and the procedures can be done with almost no operative mortality. And this allows restoration of the intestine for a subsequent procedure, because the subsequent pouch procedure can also be done laparoscopically. And you can see this laparoscopic emergency surgery has become one of the gold standards, especially in tertiary referral centers. And laparoscopic, whenever we do laparoscopic subtotal colectomy, restorative proctocolectomy is also feasible laparoscopically in these patients, and the overall results seem to be encouraging. And you can see this. This is the beautiful data that is collected to show on the various studies of laparoscopic colectomy for acute severe colitis, which shows that these procedures can be done with almost zero mortality. You can see that the mortality is zero, the morbidity is minimal, and subsequent doing that the pouch is very high in these patients who undergo a laparoscopic subtotal colectomy. The morbidity mortality is almost zero. The mortality is zero in majority of these patients undergoing an emergency colectomy. And subsequently, these patients undergo the pouch formation, and you can see this patients who are undergoing a subtotal colectomy, majority, almost 90% of them seem to undergo laparoscopic restorative proctocolectomy subsequently. So it is safe. Advantages include reduced incidence of surgical site infections, incisional hernias, and metacosmosis, pure adhesions, and lower risk of subsequent small bowel obstruction, and subsequent restorative procedures are not jeopardized. A word about toxic megacolon, I don't have to go through this. It's a highly morbid complication. Medical therapy for 24 to 48 hours with IV hydration, broad spectrum antibiotics, bowel rest, and intensive care monitoring will be very carefully tried. Cyclosporine infliximab have shown to be successfully treat toxic megacolon in only about 25 to 40% of the population. The threshold for surgical intervention must be very low, and majority of these patients, whenever they clinically deteriorate, increasing colonic dilatation, colonic thumbprinting, pneumocystis intestinalis, and imaging, I think the threshold should be low, and majority of these patients again can be done laparoscopically. And we can see the morbidity in the indications, morbidity and the mortality for toxic megacolon, hemorrhage, perforation, acute severe colitis. You can see this, the morbidity mortality is very low, and subsequently, whenever these patients undergoing the subsequent restorative or proctocolectomy, the chances of these procedures being done laparoscopically is very high, and the overall morbidity is very low. Hand assisted only in very few selective centers. Now we talk about robotic and single incision laparoscopic surgery. These are just upcoming specialties done in very selective centers, but we require further studies to better position these in the algorithms of acute severe colitis. So basically, it's a potentially life-threatening complication treated with steroids and other rescue therapies. C. difficile and cytomegalovirus must be excluded and treated if positive. Monitoring should include the CRP levels, stool frequency, frequent abdominal exams, and abdominal imaging, as stressed by Simon. Clinical instability and limited improvement in 4 to 7 days are indications for surgical intervention. Delayed surgery for ASC is associated with increased risk of postoperative complications. Multidisciplinary management between gastroenterologists, colorectal surgeons is critical to correctly choose the optimal timing of surgery. Surgical management of ASC remains a significant challenge. A surgeon's involvement is essential since the hospital admission, as conditions can rapidly deteriorate and surgical indication can be masked by intrinsic difficulties. Staged procedures with initial subtotal colectomy and ileostomy as the first step constitute the best and the safest approach. Stable patients, minimally invasive patients can initially be offered with significant advantages. Unstable patients with toxic megacolon sepsis or MODS, laparotomy could be an approach. Finally, I conclude saying that both the physicians and surgeons seem to be playing a very great important role, and it's a very close interaction between the physicians and the IBD specialists, which leads to optimal outcomes of these patients who are undergoing surgery for these complications of acute severe colitis. Thank you so much once again for the patient.
Thank you very much, Dr. G.V. Rao. I'm glad that I'm not in a debate with you on this issue, but thanks a lot for having brought out those very important messages, especially that of the fact that it should be a multidisciplinary approach. The results of surgery are good. And of course, I think a very important message which you did bring out is surgery should not be delayed to taper steroids or to improve nutrition. And I think that is very, very important. And that is something that we as medical gastroenterologists should remember. We will come to the question answer session soon after the next, that is a third session. And for the next session, which is a discussion on a very interesting case of ulcerative colitis, I would like to invite Professor Uday C. Ghoshal to conduct this case discussion. Dr. Uday Ghoshal, most of us would know, is a professor, Department of Gastroenterology at the very famous SGPG, or Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. A medical teacher par excellence, a medical researcher par excellence, a very good administrator. Very importantly, he is the first Indian representative in the prestigious Rome Foundation. He's also been on the editorial board of a lot of prestigious journals. Otherwise, I would call him the motility man of India, but then his interests go far beyond motility, and he's also very much interested in inflammatory bowel disease, and that is why he's here with us today to discuss this very interesting case. And over to you, Professor Ghoshal, to first of all introduce the panelists and go ahead with the case discussion. Half an hour.
Thank you. Thank you. I thank the IBDENC for giving us this opportunity. And we'll be discussing a case so that what Simon presented and also Dr. G.V. Rao presented, we actually recapitulate the story through one of the patients. This patient we managed at SGPGI recently, and I'll be telling you the story of the patient. Now, Dr. Muneera is from Qatar, Hamad Medical Corporation, Doha, Qatar. I remember that place very fondly. I visited probably in 2005, 6 or 7 sometime. It was a fantastic place. So Dr. Muneera from Hamad Medical Corporation, Qatar will be one of the panelists. Dr. Nilesh from Sri Lanka, Colombo, Sri Lanka will be another. And Dr. Devendra Desai, who is very much interested in IBD from PD, Hinduja Hospital, Mumbai, he will be another panelist. Let me start with the patient. This is a 60-year-old man who presented to us with diarrhea for 8 weeks. Stool frequency 20 times per day, liquid, blood in every stool. He had feeling of urgency. Sometimes he would have fecal incontinence, and he was having nocturnal awakening. He started using antidiarrheal drugs like loperamide over the counter to get rid of problem. We'll ask our panelists whether it is right or wrong to use loperamide in such a situation. He had associated diffuse crampy abdominal pain, which was moderate in intensity, and he lost weight, about 4 kg over these 2 months' time. This episode was preceded by a short story, that is, he had a road traffic accident. Fortunately, it was not a major accident. It led to injury in the right arm, but he did not have any fracture. So he just started taking indomethacin, which is a painkiller. Typically, he would take 75 milligrams slow release and indomethacin, along with proton pump inhibitor, vitamin D, and calcium. There also will ask our panelists whether what he was doing is right or wrong. Now, here's a background history. He had ulcerative colitis diagnosed 2 years ago. He remained in remission with mesalazine and azathioprine until the current episode. Before he came to us, actually some of the physicians locally asked him to increase the dose of mesalazine. So he did that. His dose of mesalazine was maximum, that is 4.8 gram daily, obviously divided. He was using steroid enema. He was using azathioprine 125 milligram daily, along with oral prednisone. But he did not notice any improvement. Therefore, he came to SGPGI. On examination, we found that all the parameters are mostly normal, except his pulse rate was 128 per minute, which is obviously high. Temperature was raised. He had mild pallor, and he had mild hypogastric tenderness. So he has abdominal sign in the form of hypogastric tenderness. He had pallor. Dr. Seaman already told you that AIMS group has removed hemoglobin. Still, they found Truloguit was doing as good. But here, this patient has pallor, note that. He had tachycardia and he had fever. Now, I have 2 questions for Dr. Muneera. One is, what is the diagnosis in your opinion? I think it is pretty simple to tell, but we sometimes wonder whether in the countries like India, we could be dealing with something else. What could be your differential diagnosis? And what could have caused relapse in him? Because he was doing very well for last 2 years. Suddenly he had a relapse. And how often and when will this patient need azathioprine? This is a question in my mind, because he came with azathioprine. That means 2 years ago, something was there for which he needed azathioprine. Just mesalazine was not doing the job. So these are the 2 questions, Dr. Muneera.
Thank you, Professor Uday, for inviting me, Dr. Aruba. Thank you all for inviting me for this wonderful meeting. For this patient, he was quite well in remission for almost 2 years, and his colon activity is almost stable with the immuran, azathioprine, and mesalamine. And now, with the current data that you are giving us, he is in severe relapse according to Truelove weight score, actually. And actually, why he did relapse in his disease, the patient recent history that is talking me of a road traffic accident and the use of indomethacin, which is considered as non-steroidal anti-inflammatory drugs. Dr. Uday, I'm not sure how long he was using or how much in dose he was using.
Yeah, you see that we are not, we did not get a very detailed account of that because it was an over-the-counter medicine. But he would take indomethacin tablets, 75 milligram, sometime once daily, sometime twice daily, and it was only for 3-4 days.
Yeah, actually, I have the concern that he developed gastrointestinal toxicity, including mucosal injury because of the use of non-steroidal anti-inflammatory. You know that non-steroidal anti-inflammatory drugs can provoke disease activity in both ulcerative colitis and Crohn's disease. They are associated with hospitalization or severe colitis flare-up. And the high dose were associated with higher disease activity index, as you know. Other differential diagnoses for him could be a superadded infection like Clostridium difficile or CMV, a standard pathogen in the colon, or as the patient who is using an immune suppressed or immune modulator medication. So always we should keep this in mind. Tuberculosis activation as well as we have to know his compliance actually to the medication, to his medication. And yeah,
please.
Please
Go ahead.
No, I mean the compliance is important. First question to ask each patient whether he takes his medication on time or not. Some people with possible low income, they might alter the dose or reduce the dose. It depends on their availability and frequency. Regarding the last question is how often these patients will need Imuran. Out of various immune suppressive drugs that we all know, the purine analogs like Imuran, azathioprine, or 6-mercaptopurine have been most extensively used and are now considered the first line for immunosuppressive. Professor Simon agree with us. This is the most immunosuppressed agent for the maintenance of remission in patients with ulcerative colitis. The use of Imuran or azathioprine is just to prevent the flare-ups in a patient who is really dependent on a steroid or as a steroid refractory or a steroid dependence. To reduce the use of steroids, as I said, and prevent recurrent and frequent symptoms.
Very good. Thank you, Dr. Muneera. I had a question. Could such relapse be related to other infections such as bacillary dysentery or amoebic colitis? Because though you mentioned all the CMV, C. diff, tuberculosis, but could it be related to bacillary dysentery, which is not uncommon in a tropical environment, and amoebic dysentery?
Yes, I agree. Any type of infection, especially in such a patient with, yes.
So we proceed further. So the question to Dr. Nilesh is how to assess the severity? Because Dr. Muneera was repeatedly saying that he has severe ulcerative colitis. And why should we at all assess the severity? And now if it is severe ulcerative colitis, how do we manage this patient now?
Thank you, Dr. Day. I would like to thank AIG, Rupa, and the IBDENC group for inviting me to for this discussion. The answer to these questions has already probably been discussed with by Professor Travis on complete lecture. So just let me just go through the things again. So how do you say severity? Probably like Professor Travis said, probably the most widely used and clinically relevant and probably the easiest to remember would be the true love and its criteria, where the components would be the fever, hemoglobin, the ESR, and the pulse rate, and together with the stools frequency. So if we put it on this patient, he had stools frequency I think more than 20 times a day. He had the tachycardia, his fever, he had his temperature was more than 99. So he would definitely fit into acute severe ulcerative colitis. So the importance of assessing severity has also been discussed in Prof. Simon Travis's lecture. So the most important thing for us to remember why we assess severity is to decide whether we want to admit these patients for inward care, or you would probably want to manage this patient as outpatient care. And also, like Prof. Travis said, to give us a gauge, to give us a kind of a prediction of how these patients will respond to the treatment that we are going to start. So just to reiterate the management steps, the first thing would be, number one would be steroids. We generally combine IV steroids with rectal steroids. Number two would be to hydrate these patients well, because they will be having diarrhea and they are at high risk of developing thrombosis. So we would hydrate these patients well with ringer lactate or Hartmann's, maybe 2-3 liters of fluid per day. You prophylactically anticoagulate these patients with subcutaneous heparin to prevent thrombotic episodes which are associated with acute severe relapses of ulcerative colitis. And something which Prof. Travis used to reiterate so many times when I was working with in Oxford was preemptively correct the potassium. Not correct, actually, to replace potassium. Don't wait till the potassium goes down. When it's too late for us to be able to correct the potassium. So because of diarrhea, patients will be on steroids. So make sure that you correct to replace the potassium by giving 1 milliequivalent millimoles per liter of potassium. And the place of antibiotics, probably it was not discussed, but from Asian point of view, and definitely in Sri Lanka, we would give antibiotics at the beginning, IBD-metronidazole and ciprofloxacin, and do the cultures, stool cultures and the C. diff toxins, and probably decide on whether we continue them after about 2 days once we get the reports, or whether the patient is going for surgery or not. The basic bloods will be done, like the full blood count, the electrolytes and the creatinines, and maybe X-ray. And would want a stool frequency chart started, and a sigmoidoscopy be done, probably unprepared sigmoidoscopy to, like Prof said, to look for evidence of the disease, and also look for cytomegalovirus involvement in the colon.
So very good. So what we did is, these are the investigation. His hemoglobin initially, as you can see, was low, very low rather. And after 2 units of transfusion, it rose up. His total leukocyte count was raised. His ESR was 56, which is very high. C-reactive protein was high. His albumin was low. Fecal calprotectin was 1760 milligram per kilogram of the stool, normal being 50 milligram. So it was very high. This has been already reiterated several times by Dr. Travis. His liver function test was normal, creatinine normal, stool did not show any organism, stool C. diff and did not receive any toxic megacolon. So Dr. Desai, what is your prediction now that this patient would respond to medical treatment? And if you predict, I would ask you, how did you predict that? And what is the relationship between C. difficile and ulcerative colitis? So these are the 3 questions for Dr. Desai. But I want a quick response because we have spent already 12 or 13 minutes. We have more 15 or 16 minutes.
Can you hear me?
Yes.
Okay, so let's summarize this patient. This is a patient who is already on azathioprine and oral steroid. His current relapse is probably related to non-steroidal anti-inflammatory agent. He has low hemoglobin, low albumin, high CRP, and calprotectin more than 1000. So this patient may be refractory to surgery. And how do we say it? That there are multiple recent studies that have been shown by Professor Simon Travis, and also you have yourself used artificial intelligence and concluded that low hemoglobin and high CRP is useful. So that is the answer to the first 2 questions. And the second question is, what is the relationship between Clostridium difficile and IBD? So patients with inflammatory bowel disease have nearly 3-fold increased risk of developing Clostridium difficile infection. So it can be a cause of relapse. And patients who have Clostridium difficile infection in a patient with IBD have higher rates of colectomy and death, and they experience higher rate of recurrence. Thank you.
Okay, very good, very good. Now, so we go further. We did a flexible sigmoidoscopy prepared. It showed multiple ulceration, friability, erythema involving whole of the rectosigmoid. This was reported as Mayo grade 3. We took multiple biopsies for histopathological examination. We also sent real-time polymerase chain reaction for cytomegalovirus. Now we started on IV hydrocortisone, 100 milligram 4 times daily. It is needless to mention that all these patients get antibiotic in our setup, typically ciprofloxacin and metronidazole for 7 days, because it could be related to infection as well. So particularly in our setup, we do that. We also give obviously heparin subcutaneously, because these patients are at risk of thromboembolism. Here we continued azathioprine, mesalamine, and steroid enema as he was taking. You will say, why in a severe ulcerative colitis, when you are giving systemic steroid, you give steroid enema? There are studies to show in such patient, you give systemic steroid alone, it takes time to recover. Whereas if you add enema as well, So it it is shorter, time to recovery is shorter. At day 3, stool frequency was still 12 to 14 per day, bleeding with all the stool, CRP is still high. So therefore, we concluded that there was no response by day 3. This was already predicted by our great sort of predictor, that is Dr. Desai. Now what happens is day 3, one new problem started. He started having fever. It is temperature is shown below in Fahrenheit. You can see 100 degree Fahrenheit, then 199 and so on. So this is a new problem that started, fever on day 3, and it continued. So I'll ask Dr. Muneera that what could be the causes of fever in such a patient? Yes, Dr. Muneera, can you unmute and educate us what could be the causes of fever in such a patient?
Yeah, such a patient, there is variable causes of fever I can think of. The activity of ulcerative colitis itself can cause fever. Infections, any sort of infections can cause fever. And as well as we know, the hemophagocytic syndrome as well might be the cause of his fever.
Can it be other infection like CMV? Can it be COVID-19, because the COVID-19 pandemic is going on and he was managed March 2021?
Yes, and in this era, COVID-19, still we don't know a lot of information about it, but such a patient, if there is a COVID-19, I expect that patient will be in severe case scenario COVID-19 infection. He might be intubated or not. He will be sick enough to have such a flare-up.
Okay, so let me give the information. We got his COVID-19 done before admission. He was negative, but again, we repeated COVID-19 and he was still negative. So this patient did not have COVID-19 as the cause of fever. So now I asked you how to treat him now. Because we have given steroid 100 milligram, he did not respond.
Yes, if CMV, as you said, result not yet ready. So despite the growing use of the medical salvage therapy, and if patient not responding, as we know in the 3rd or 5th day, so colectomy might be remained the concern, and there might be the life-saving for this patient, especially in severe colitis. Whether he's an elderly and children, they are in the same predictor. Colectomy should be regarded as a life-saving, as I said. If patient receive the salvage therapy like infliximab, cyclosporine, and the 3rd day assessment, we should bring our surgeon early in this patient.
Okay, so actually, yes, we considered colectomy, as Dr. G.V. Rao said. We, the physician, often tend to delay the most definitive therapy, but the patient actually did not want that. He declined colectomy. Biological cyclosporine with the other option considered, but at this time we received the report that CMV PCR that we send in the colonic tissue came as positive 1260 copies per milligram of the tissue. Hematoxylin eosin stain showed cytomegalovirus inclusion body. So therefore, we started IV ganciclovir, 5 milligram per kg twice daily. We gave it for 5 days, and then we changed to oral ganciclovir, 900 milligram twice daily for 3 days. Day 7, his stool frequency became 4, no bleeding per rectum. Symptomatically, he felt better, and he remained well on follow-up on the same treatment. So now we will ask Dr. Nilesh that can you educate us about CMV and ulcerative colitis? What are the definitions? Let us say if we just do CMV antigen test, CMV antibody test, or CMV tissue PCR, or CMV blood PCR, we get confused which one to interpret how. So can you educate on this?
Yeah, it's actually very confusing, but so I'll just make it very, very simple. So when you're discussing or looking at the CMV issue of CMV and ulcerative colitis, there are two terms which you need to always think of. One is CMV infection, another one is CMV disease. CMV infection means just the mere presence of the infection in the tissue. It doesn't mean that the patient is actually having disease due to the CMV infection. Of course, CMV disease means the presence of infection plus the end organ damage. Okay, so differentiating these two is very important because the treatment is going to be different. And clinical parameters is sometimes very difficult to differentiate because the symptoms are going to be different, although probably endoscopically punched out ulcers are suggestive of disease, although it's not very specific. So what are the investigations which are available? With Dr. Prof. Uday has already put up on the screen. You get the blood test and you get the tissue tests. Tissue as in the colon tissue test. The blood tests are the serology, the CMV, IgM and the IgG reports, the PCR and the antigen reports. Generally, these blood tests are not very, don't correlate very well with the active colitis of CMV. For example, if the CMV IgM is positive, does not actually mean that the patient always has CMV colitis. For the bit, of course, there are studies which have shown if you quantify these tests, the CMV PCR level and the antigen level, which might indicate there's an active colitis going on due to CMV. The better test would be to look at the tissue samples. You can on H&E and also on immunohistochemistry and also the PCR assays on the tissue samples. You can look at that, and that will probably correlate better with the disease activity or CMV activity in the colon. There are quantification methods which are done, which probably Prof. Uday will discuss further in his next slides. The second question was the risk factors. The common risk factors are age more than 30, female gender, and severe inflammation and pancolitis, and of course the presence of, or if the patient is already on steroids and immunosuppressants, these patients are obviously at more risk of developing CMV colitis.
Yeah, so very good. So here are the list respected Dr. Nilesh has already mentioned about this associated with CMV, then Crohn's disease, because it is implicated because of the two differing immune pathogenesis. Ulcerative colitis, primarily TNF mediated, and Crohn's disease are different immune pathogenesis. So Crohn's less often have activity of CMV. Now CMV in IBD, let me tell you the few tips. So one is, this is the meta-analysis. This meta-analysis tried to look at antiviral therapy in steroid refractory UC with CMV. Now what it shows is 15 studies. Obviously there are hardly any study which are randomized controlled trial. These are observational study, but these studies tended to show that if somebody is CMV positive, particularly if the CMV PCR shows high number of copies of CMV DNA, or if there are multiple IHC eye inclusion body, this patient benefit from the anti-CMV treatment like our patient did. Accordingly, this is the current algorithm. If there is a patient with steroid refractory or dependent moderate to severe ulcerative colitis, so it is referring to those patients who have moderate to severe UC. If a patient has mild disease or disease in remission, if CMV comes positive, you can ignore it. But if it is a moderate to severe UC and you test for CMV, and if you get high-grade CMV defined as more than 5 inclusion body per biopsy. And remember one thing, that hematoxylin eosin stain inclusion body positivity rate is very low. In fact, one of the study that we published around 2003, that was one of the initial study that showed that CMV positivity is associated with the worst outcome in UC. So in that study, we found in only 10% we could pick up CMV inclusion body in colonic biopsy, because that time we used only hematoxylin eosin stain. Nowadays, standard of the care is you have to use IHC or immunohistochemistry, in which you target the antigen of the CMV. So you do IHC with the antigen of CMV, and in that situation, your positivity rate increases from 10% to 90%. So if you get more than 5 CMV inclusion per biopsy, or if you get more than 250 CMV DNA per milligram of tissue, in our patient, we got almost more than 1,200 copies of CMV DNA. You should treat them with anti-CMV treatment like we did. What is the anti-CMV treatment? IV ganciclovir, 5 milligram per kg twice daily for 3 to 5 days, and then oral vancomycin 900 milligram twice daily for 2 to 3 weeks. Low-grade CMV, meaning thereby that less than 5 inclusion body per biopsy or less than 250 CMV DNA per milligram of tissue. If they're corticosteroid responsive, you can just continue corticosteroid. Our patient, unfortunately, was not corticosteroid responsive. But if he's corticosteroid refractory, then there also you give anti-CMV treatment. So this is my final slide. But before we open this case for the panel discussion or question answer, we have 2 experts, the world famous experts on IBD. So I will request for their comment, Dr. Simon Travis and Dr. G.B. Rao. On this case, your comment.
Good. Well, thank you. That was very nicely discussed today and presented, and interesting. I would normally say that CMV tissue infection would cause a higher fever than the 198.99, to be honest with you, because that's my experience. We see it infrequently in Oxford, but it's a really important point to think of other infections, and of course that depends on the area you are. But you treated her appropriately, and always needs to be considered. I haven't used azathioprine for 15 months. Haven't started it on any patient. Because I go straight to, I think the pandemic has been such that in a wealthy country, which I think includes the UK, we can go straight on to anti-endocrine therapy out of choice in these patients. So we often use cyclosporin as a bridge to do anti-endocrine, and I think that's a safer option. But Muneera went through all the other options. I still think that the point that Dr. G.V. made about the tripartite decision-making about colectomy, even if patients don't come to colectomy, it really helps for the patient, their family, to have had a chance to discuss through what surgery might involve, because it may happen on another occasion. And you have to have that discussion at an early stage, because this is the first time they'll ever have come across it. Whereas for you and me, we say this frequently and are familiar. But I think that it's it's a useful opportunity, even if you find a way out of it by treating their CMV or C. diff or whatever it is, and they avoid colectomy. It's still a useful opportunity to have that discussion. So well discussed, and a nice case presentation.
Oh, thank you. Now I would like to give some comments because there is always a little difference between the West and the East. The reason is, I'll tell you, one is that he is elderly, 60. He was on at least 2 immunosuppressive, that is steroid, and second is azathioprine. So maybe his febrile response could be low because of steroid, azathioprine, and older age. And second is, interestingly, in our experience, we got a lot of patients in whom CMV was activated, even not having fever. Because my idea is that if CMV primarily gets activated in the colon, now what you will get is you may not have very high fever, but you will have colitis. On the other hand, if you get generalized CMV disease, where you get typical those atypical lymphocytes, typically you get large number of atypical lymphocytes more than 10 per high power field. Like we get atypical lymphocyte in infectious mononucleosis, we know that. But in CMV also you get atypical lymphocytosis. You may get even leukopenia because CMV disease causes leukopenia. You can have pneumonitis in CMV disease. You can have hepatitis in CMV disease. And these are the patients where we find there's a higher temperature. So they have a generalized CMV disease with atypical lymphocytosis, pneumonia, hepatitis, sometimes even mild neck rigidity. Whereas in absence of those, it is a local activation in the colon. I agree fully with you, azathioprine is a concern, but typically we tend to use azathioprine more because of the cost issue. I think Dr. Gian Ramesh will agree with me. Am I right, Dr. Ramesh?
Yes,
and
yes.
Dr.
Right.
Dr. Doshal, can I ask one question to expert in East and West?
Yes. Yes.
So we have these criteria which tell us that okay, steroid is going to fail by day 3. But in practice, when do you take the decision to go to salvage therapy? Is it day 3, day 4? Because we find that there is a little delay in that decision, maybe day 4 or day 5. One of the Italian studies says that they decide by day 7. So I want to know this opportunity.
I think, Dr. Devendra Desai has asked this question, and Dr. Mohsin from Bangladesh has also asked the same question. May I request Dr. Simon to just answer this? When exactly? Day 3, day 4, day 5, day 6?
It's a fundamentally important question. Remember that the action that I recommended on the 3rd day, when you've got that, so this is likely to go bad, you have the discussion with the patient and you get the surgeon involved, and then you talk through with the patient about starting rescue therapy. And so we normally start rescue therapy on the 4th day. So because, results come back in the evening, you get involved, you have a chat with the patient that evening, get the surgeon involved, and you start rescue therapy and get the surgeon involved in parallel. I do not wait for the rescue therapy to fail before I get the surgeon involved, because the patients and their families, so important, have so many questions. And I believe that the toxicity of cyclosporin 2 milligrams per kilogram or infliximab, assuming you've done your pre-flight checks and you've more difficult in India or where TB is endemic, but the toxicity is low. It's a very, very acceptable. What you end up doing if you wait until the 5th, 6th, 7th day is you think, I wish I'd started that sooner, and I much sooner have that. And then you know where you are, and the patient, you take the patient with you by the hand and the family with you by the hand.
Dr. Mohsin has asked one other question. By initiating an early use of biologicals, do you think the need for colectomy would come down?
Yes. Yeah, I mean, I was really taken aback by this, and it was Jack Sasangi with us in Oxford, who's really did the work with Vipin Gupta. And I didn't think that the colectomy rate had come down, but it very, very clearly has shown that the increased use of rescue therapy, and that includes cyclosporin as well as infliximab. I'm not by no means giving infliximab all the credit, but the increased use of rescue therapy has led to a halving of our colectomy rate from 30% down to about 14%. So I do think that is, and we're often accused of having too low a threshold for colectomy. I mean, we're fortunate having good surgeons, but we have not yet taken out a colon and discovered that they've had untreated CMV, I'm glad to say. So what do you do? It's a question to Uday or to you, Jonathan, that if you don't have immediate access to tissue PCR for CMV, what do? I mean, how do you decide whether they've got CMV, or do you just send it away and hope that you get an answer within 48, 72 hours?
Yeah, typically what we do is that if there's a patient of acute severe colitis, particularly who is on multiple immunosuppression like this patient was, and we have to do a sigmoidoscopy, unprepared sigmoidoscopy for histology, for looking at the activity. Same time, we send CMV for PCR. And in the earlier days, I tell you, in 2002 or 3, we never treated this patient with anti-CMV therapy. That was not as per protocol. So therefore, what we realized is that we did a study on 60 patients. We published that paper in Journal of Medical Microbiology. And what we found is 10 patients had CMV by CMV PCR, by IgM antibody, and inclusion body. And what we found is these 10 patients, where they were managed as usual, like physician was managing as usual, like we're managing as usual. They landed up with colectomy more, they landed up with perforation more, they landed up with even death more often, compared to those in whom the CMV was negative. And that was the starting point in 2003. We actively started looking for CMV, and we started treating. Even I will tell you, earlier days, we did not even look at copy number of CMV because RT-PCR was not so widely available, but we treated them with anti-CMV therapy. But later now, we always look at the copy number of CMV. If the copy number is high, then we treat with anti-CMV therapy. Another thing we have seen, if somebody is responding to drugs, if you gradually taper off the steroid, they become really well, because that means if you give a lot of immunosuppressive, when a patient is already CMV positive, he does worse than a fellow in whom gradually you taper off steroid because that fellow responded to your acute therapy.
That's the importance of the CMV. But then just quickly, Uday, in your setup, how long does the PCR take?
It doesn't take so much time. Like I'll tell you, my advantage is...
No, is it available to you on day 3 or day 4?
Yeah, it is. Because you see, now we are doing RT-PCR for corona. It is available next day. And my wife is a medical microbiologist.
Okay.
So
okay, Simon, a question all the way from...
Yes, Professor Ghoshal.
Yes.
Okay. A question to Professor Simon, all the way from Israel. Dr. Idan Goren has asked, how common, we see in recent years patients admitted with acute severe ulcerative colitis after failure of infliximab, for whom we use either cyclosporin or tacrolimus as a rescue agent. What is your experience with second and third line rescue therapy?
Yeah. Pretty poor. I mean, GV gave the figures, and it depends on the whether you're prepared to accept the high risk of pneumonia, liver abscess, and so on and so forth. I have to say that if we have a patient with ulcerative colitis who's been on infliximab and comes in with acute severe colitis, well, we've usually had a dialogue already and about next steps. And so if you see them slipping down before they get to acute severe colitis, we'll change, and I'll certainly, whether you deploy vedolizumab or switch to tofacitinib or even ustekinumab, we have those options available. But I do also, when I'm doing that, make sure they see the surgeons as an outpatient, just in case, as preparation. If they've genuinely got acute severe colitis, in spite of infliximab, you're up a gum tree. I think I wouldn't give cyclosporin as well. I think that you can, that they respond to intravenous steroids. You have a chance to transition them on to vedolizumab, which I would consider a safe option. And one patient, I've got the most wonderful daily symptom diaries over a 2-year period with our True Color system of somebody who clearly needed a colectomy, was not fit for a haircut because of a diabetes and so on and so forth. And we gave a tofa, and it worked just wonderfully. Peter Higgins in Ann Arbor has been advocating the use of tofacitinib high dose. This is off license, I should emphasize, of 10 3 times daily for acute severe colitis. Of course, you've got to balance up the risks of colectomy against the risks of immunosuppression. And I pick up the phone and call a friend. I mean, I just go down the corridor and speak to a friend, because but you do need to speak to an experienced colleague. Share that decision. It's really important.
Okay. Over to Dr. Jayanti for the questions.
Dr. Uday, your patient had low albumin, so I'd like Professor Travis and the panelists to come up with the nutritional management of these patients, especially when they are suffering from acute severe ulcerative colitis. We've not touched upon that. How do you manage the nutrition?
Can I pitch in there? First of all, I would say, Jyoti, the albumin is not a marker of nutrition, of course, as well. You know, I mean, it's an inflammatory marker, and a low albumin TNF switches off albumin synthesis. However, nutritional management is really, really important, and I never understood how important until Vineet did that that randomized controlled trial of using using enteral nutrition. This was an open study, but randomized study, open label randomized study, which was published in Elementary Pharmacology Therapeutics in January of this year, clearly showing a benefit, both short-term and length of stay, short-term and colectomy, long-term and colectomy, for giving them enteral nutrition. And so it isn't harmful. Some people, a few, can't tolerate it. So we give all of our patients enteral nutrition now. It really has been a practice changer, and we never used to.
Dr. GV, a question to you from Dr. Idan Goren from Israel. He says, he's asking you, how common is chronic pouchitis in patients after pouch surgery in India? These patients somehow seem to replace one type of IBD with another and often require immunomodulatory or biological treatment to control pouch inflammation. What is your opinion?
Dr. Travis would have to answer. I think GV is...
That's okay. Well, actually, I think it's a good opportunity to do so, because I can announce, since the results have just been made public, that there is a treatment for chronic antibiotic resistant pouchitis, CAR, that works, and that's vedolizumab. It's going to the European Medicines Agency, and it is the first effective treatment for chronic antibiotic resistant pouchitis. But I think it's a fair comment that people seem to switch one form of inflammation to another. And of course, it's their inflammatory phenotype. It's why you get extraintestinal manifestations. I think it's worth remembering that people with extraintestinal manifestations, especially primary sclerosing cholangitis, have a higher risk of pouchitis if they have pouch surgery. And we use that as a factor in deciding whether to do a pouch. I think patients need to be very well informed and often spend some months, even longer, thinking about whether they want to be completed, because some people think if they have a proctectomy and a permanent ileostomy, it's not such a bad option, because a poorly performing pouch is a pain in the proverbial. And I think that it's and it really is, they say, what have you persuaded me to have?
Partha, any question from your side?
I would like to ask one basic question. We have panelists from Pakistan and Sri Lanka. How often would you see an acute severe ulcerative colitis, say, in a year, from UK, from Sri Lanka, from India, and...
maybe Dr. Nilesh can answer.
Yeah. Please let us know the number of cases you would see, because at least I don't see that many. I see 2 or 3 in a year. Yeah.
If you ask which in the hospital which I work, only probably we see about 25 to maybe about 25 patients a year. But these are only for the hospital in I'm working.
That's a big number.
It's a big number. Uday, number of cases per year?
Yeah, we see quite often. I would say around 25 to 30 per year. But as with my increasing interest, the IBD, I'm getting more now.
Okay,
Down south, I think it's much less. I don't know. I stand to correction.
Yeah, the time's 8 o'clock. I think we have to wind up, but it's not that we are winding up the discussion now. This is just for your information. We will continue this panel discussion or the question answer session after the formal closure of this meeting. Over to Dr. Rupa for the next part, which is actually the cultural part of this program. And as you would have noticed, this episode of IBD ENC Masterclass is actually dedicated to our Thai friends. So over to Rupa for welcoming our Thai friends for their brief introduction.
Thank you, Dr. Ramesh. And it is true, the whole spirit of IBD Emerging Nations Consortium is to have everybody from the region on the same platform. We have same challenges, diagnostic and management for IBD, and IBD is emerging in this part of the world. So it is a great pleasure to introduce my close friend, Dr. Pise Pongsa. He is a professor with the Bumrungrad International Hospital, a keen enthusiast in IBD. And as I speak, the only thing I can think about is his extensive work on IBD and how good a friend he is, a key member of the IBD ENC. Together with him, we have Dr. Julajak Limsrivilai, again a close friend, and he is from the, pardon me if I pronounce it wrong, he's from the Siriraj Hospital, and again keenly interested in IBD, has got very nice papers, tuberculosis and Crohn's, a key part of our IBD Emerging Nations Consortium, and of course the most beautiful Dr. Satimai Anivan. She is an associate professor at the Bumrungrad International Hospital as well, and a core member again of IBD ENC. They have prepared a very nice story about Thailand. This is all it is about in all the pandemic, what is there in each country, getting to know each other. So Pise, I would just ask you to say a few words about Thailand before we show your video. Over to Pise.
Okay. Thank you so much, Rupa. We Thai doctors are very grateful for the chance to join this very fruitful and very friendly meeting. And we are looking forward to a next one. So Dr. Julajak, Dr. Simai, and me have some presentation about our country. So please see.
Yeah, the video. The video, please. And you can see all of them there. Sound.
People are generous, cheerful, and independent of spirit. Whether they live in the town or countryside, they always respect their elders and are open-minded, and tolerant toward both local people and visitors. Thailand is an ancient nation with a unique national culture, with its own language, religion, literature, art, music, cuisine, and fashion.
Thai food is well known as one of the top food in the world. It is unique and has a different taste from other countries. Not many countries that have various kind of food like in Thailand. There are a great number of famous menus that you must try, such as Tom Yam Goong, Masaman, Som Tam, and Gang Kheo Wan.
Is a popular country where many people around the world would like to visit. We have amazing nature, beautiful culture, and yummy Thai foods. A journey always starts in Bangkok, the fascinated capital city, as it's easy to travel to other provinces. For example, to the north of Thailand, Chiang Mai, Chiang Rai. You can go to see mountains, local culture. Furthermore, you can go to the west of Thailand, such as Kanchanaburi, the province with a historical history of liverware. Whether you can go to the south, where there are a lot of seasides like Phuket or Krabi, is a top destination in this climate.
Since there are not many countries ready to open for new experience of various traveling, because of fascinated culture, plentiful food, being generous and humorous people, no wonder why here is the destination many tourists want to visit. And all of this is Thailand.
Thank you so much.
Thank you, Thailand, the land of smiles, and it's really, this wonderful video has made us all smile. Almost got the feeling that we had reached Thailand.
I think Julajak would like to have a word for the IBD-ENC. You're muted, Julajak.
Okay, good evening.
Yes.
Yes, we can.
First of all, I'd like to thank you for including Thailand in the IBD-ENC group. Because Thailand is like other countries in this region, that IBD was rare in the past, which make many doctors in my country feel uncomfortable to treat this disease. However, as you know, I think everything will be changed in the near future because the incidence and prevalence of the disease is increasing. And so all the activities that you organize and the projects that we are collaborating, I think it will be magnificent and very useful. Thank you very much.
Thank you very much. That was interesting, and we look forward to your continuing and increasing participation in the IBD-ENC proceedings. Thanks very much for that wonderful video too. Well, I'm a stickler for time, and I'm a happy man today because we are just 2 minutes ahead of schedule, and we have almost completed whatever we aim to do. Of course, we'll be continuing the panel, the question answer session after the formal closure, which I mentioned before. And I now hand over the proceedings to my course director, Dr. Jayanti, for the closing remarks and, of course, to announce the next meeting as well. Over to you, Dr. Jayanti.
Thank you, GN. On behalf of the IBD-ENC and my co-moderator, Dr. GN Ramesh, we profusely thank Professor Travis for enlightening us on the various predictors of outcome on various clinical, laboratory, endoscopic, as well as various other indices at the time of admission, as well as at the time of during the admission. And to Dr. G.V. Rao for giving us an excellent exposition on the need for surgery and the indications in acute severe ulcerative colitis, and for an excellent discussion by our panelists with Dr. Uday on the lead on highlighting the role of CLV colitis in patients with acute severe ulcerative colitis. Thank you all, and we thank also the participants for the extensive interaction, which we acknowledge, and the wonderful presentation, the video presentation from Thailand. Over to Dr. Rupa for telling us what will be the next program that is going to be in the month of June.
So, yes, so the next program will be equally interesting, and you can see the poster on the screen. It is COVID-19 and IBD, all you need to know. This will include how to prevent, how to treat, and how to vaccinate, when to vaccinate. The entire story from leading international experts from Hong Kong, Israel, Malaysia, and of course, India here. And the theme for the next meeting, the country will be Sri Lanka, and I hope to see all of you there. I take this opportunity once again to thank our academic partners, of course, from at AIG Hospitals, Asian Healthcare Foundation, and our partners are Dr. Reddy Labs, Microlabs Limited, and Takeda. No academic meeting is successful without some partnership, and we are grateful to our academic partners. As we mentioned before, we've had actually a deluge of questions which came during the meeting. So we would request those who ask the questions to be available now, because our panelists and Professor Travis will now take on those questions. So,
okay, Rupa, thank you very much. Well, we continue with the question answer sessions. I hope our panelists are there with us. The Professor Simon Travis is there. So I'll set the ball rolling once again by asking Professor Simon Travis a very simple question to start with. Do we regularly need to send tests for CMV in all pancolitis patients? Would you do that in clinical practice? This is a question from Dr. Ram Krishna Baral.
Yeah, I must say that I wouldn't. I think that despite the higher prevalence in India, I think I still struggle to understand why it is, although the infectious burden is, of course, much higher. And I wonder whether it is in any way related to the use of steroids, because we don't know what the overall steroid dependency rate is. So I wouldn't, but I would have a low threshold for sending off biopsies and immunohistochemistry and PCR if you've got access to it. If you've got somebody with the relapse which isn't rapidly responding, or if the relapse is severe.
Okay. Dr. Partha, you had a question.
Yeah, I had a question to all the panelists. So what is your experience regarding the use of exclusive enteral nutrition in these patients with acute severe ulcerative colitis? Have any of the panelists used it, and how was the response? Just wanted to know. I've used in few of my patients and I got short-term good results, but I found difficulty on how long to continue the exclusive enteral nutrition, when to transition the patient diet from exclusive enteral nutrition, and also when to call whether the patient is non-responding to that. Any take on that from the panel?
So perhaps as a co-author on the AIMS paper, what I would say is that it's not exclusive enteral nutrition on its own for treating acute severe colitis. It's as an adjunct to standard treatment with intravenous steroids. And what you do there is you increase the responsiveness to steroids, and therefore we give it for the 7 days that they're in. In fact, after about they're responding to steroids on or around the 5th day, we would then get onto a normal diet and then and transition them from intravenous to oral steroids. So I don't think it changed the timeline. It just improves the outcome and responsiveness to steroids, and we still use rescue therapy if that is indicated according to the predictive indices.
Okay, a question to you, Uday. You mentioned about using heparin as a prophylactic measure. Do you think with the advent of the newer anticoagulants, would you like to go in for the newer orally active anticoagulants rather than going in for an injectable medication like heparin?
Yeah, you see, you can also use the newer one, but typically when the patient is sick, admitted to the ward with severe colitis, you know, every patient who is sedentary in the ward are at a greater risk of thromboembolic complication. And interestingly, people have shown by studies that ulcerative colitis patient or IBD patient are at a greater risk of thromboembolism than other GI patient. Second is also, there are studies once upon a time where people found that heparin, when it was tried in a randomized controlled trial, ulcerative colitis patient, heparin itself tended to give relief to this patient. Maybe there are microthrombosis in the vessel, and that is important in the pathogenesis of ulcerative colitis. So with all this keeping in mind, I will give either heparin, or a better one will be something like low molecular weight heparin, where we don't have to monitor really very extensively. Then in a high risk patient, you can actually transition them with a short period of oral anticoagulant, but we don't feel that is really necessary. But I like to give low molecular weight heparin when the patient is admitted.
Okay.
I have a provocative question, Dr. Ramesh, and
Yeah.
this is for all of the panelists from this part of the world. So tofacitinib has just become available. So there is actually a question from Dr. Uma Shankar. It's just come in, and they say that can we, because affordability is a question, can we use tofacitinib in acute severe ulcerative colitis? Is it worth a try? Because apparently it works fast in some patients. So I think, Simon, your comments, as well as some of the panelists, I mean.
So I may be best placed to answer that, because I declare an interest, having been the reviewer for gastroenterology for Peter's submission of his cohort of patients that he's been treating in Ann Arbor in Michigan. And the short answer is yes, but it's a bit more complex. If you go on the just under 50 patients that Peter's Higgins has been treating over the past, I think, 3 years with tofacitinib, he finds that that needs high dose, 10 milligrams 3 times daily, which is a big dose. If you consider 10 milligrams twice daily as what we would normally use as tofa for induction, then 10 3 times daily is a high dose. I think you have to be very, very chary, though, that although it's an option, what other options have been tried in the past? It comes back to that question from Israel about what happens if you're treating somebody who's relapsed on infliximab. What other treatment have been tried? Because patients are desperate to find a medical answer, but sometimes the medical answer is the wrong answer because of the complications, and I'm very chary of multiple immunosuppression. So I think that it is it's up to Ann Arbor or other places to do a trial of tofa rescue versus the standard of care, because tofa is not without its problems. If it is associated with venous thromboembolism 1 in 1,000 patients, then you could argue that you should give extended thromboprophylaxis even after discharge if it works. And the 1 in 100 getting shingles, there are of course other problems, cyclosporin, other problems with infliximab, but we need to be careful about saying, oh, just we've got a new toy in the cupboard, let's go and play with that.
I think it is a very important point. If you give me maybe 30 seconds, you see that tofacitinib we tried in some patients for rescue therapy. It worked, but as Simon said, it is associated with peculiar complication, including the look at this patient. Let me share with you the picture of the patient. Here is it. So we started her on tofacitinib, and this is what she had. She had herpes. So therefore, infectious complications particularly are common in countries like tropical countries, so one has to be careful.
Okay. Uday, sorry, Jim, can I just, Uday, you should have at least shown some discretion blanking out the eyes there. I think it's be very, very chary about showing full facials of patients. But maybe I'm just sensitive about it in the West, but it's patient confidentiality. But it is an interesting, you make a very valid point. And coming back to your point about CMV, you know, I do get exercised about TOFA, shingles, and the herpes viruses and CMV. So it's a fair point to make.
I thought it was.
I'm sorry because I did not get time to cover up because it was there in my computer. I hope patient doesn't mind, and they don't usually in our country.
I thought it was mentioned during the course of the panel discussion that non-steroidal anti-inflammatory drugs are a risk factor for relapse in ulcerative colitis and Crohn's disease. What do the statistics say, Dr. Uday? Ulcerative colitis, I would believe so, but Crohn's disease?
Yeah, I'm not particularly aware about any statistics. If Dr. Simon knows, it will be great. But what happens is it is mechanistic, because what happens is whenever it blocks the prostaglandin pathway and then divert, you see, because that's why people have said maybe the coxibs are safer, but I tell you, when coxibs have a lot of complications, including vascular thromboembolism. We know the story of coxib in the US. So what happens is, but there are limited data saying that coxibs are better, but these are not very well controlled studies. It is mediated by blockage of prostaglandin, prostacyclin, and arachidonic acid pathways.
Yeah, I agree. I mean, all the data has really come from UC ever since Chris Hawkey, as a research fellow, Sidney Truelove's last research fellow, was the first to report it with David Rampton about non-steroidals being associated with a flare of colitis. Trouble with Crohn's disease, you've got small bowel Crohn's disease. Not only can non-steroidal produce an enteropathy, that's uncommon, thank goodness, but you just sort of think if they've got a bit of ulcerated small intestine from Crohn's disease or even an incipient stricture, and then you have a tablet lodge or non-steroids going through there, you may get a local effect causing ulceration. I try and avoid them, and the coxibs, there was a controlled trial that Bill Sanborn did suggesting the coxib short-term use not associated with any more complications, but I try and avoid them if I can, and use more effective treatment for their arthritis.
Would you think that rectal non-steroidal anti-inflammatory drugs would be safer if it is required?
Fair question. The evidence from the GI bleeding literature is that they are no safer. Topical therapy appears to be safer, but they're probably less effective on the joint. So in other words, I'm talking about the non-steroidal creams and so on. So I'm not sure that rectal therapy is necessary, but that's extrapolating from the GI bleeding literature.
Dr. Jayanti, you have a question.
Yeah, Dr. Uday, there's a question from Dr. Ramesh. What if your patient would have had undergone surgery if he was not responding on day 3?
Yeah, actually, as I told you, as Dr. Simon said, as Dr. G.V. Rao said, all patients in day 1 are shown to surgeon in our setup. So it is not even day 5. So we co-manage patient of acute severe colitis. It is a conjoint decision between medical team, surgical team, and the patient family. And in fact, I tell you, the moment a patient is taken up by the surgeon, I'll feel happy, because I don't want a patient sort of getting a perforation or complication. So we never try to deny surgery in acute severe ulcerative colitis. In this particular patient, surgeon wanted us to go for medical therapy, particularly CM became positive, and the patient declined biological, cyclosporine, and surgery, all 3. So therefore, we had no option but to try a therapy against CMV, and we were lucky that the patient responded. Otherwise, acute severe colitis, if there is toxic megacolon, I will want within day 3 or day 2 patients should be operated. If it is not toxic megacolon, day 5 is the maximum. Like you look at the paper from Ames group, They showed in whom surgery was delayed beyond 5 days in acute severe colitis, the complication was more than if you did surgery within 5 days, and we follow that protocol.
Just a linked question, Professor Simon. Is there any data to tell us whether a missed C. diff or a CMV infection is associated with worse surgical outcomes?
Interesting. I don't think that there is. I would say that the commonest indication for colectomy in toxic megacolon in our hospital these days is C. diff. So we rarely see toxic megacolon in ulcerative colitis, to be honest with you. And we know from all sorts of case series and whatnot that if you've got ulcerative colitis and you've got C. diff, so you've got a double whammy, well, guess what? The outcome is worse, and the surgery rate is higher. I think that it is good practice, and I'm sure, I hope is universal practice, is that any patient admitted with acute severe colitis has a C. diff assay sent off for both A and B toxins, but it's amazing how sometimes those get below the radar, but I'm not. I think I mentioned too that in all of our patients that we do about 20 colectomies a year for acute severe colitis. We do have a high number of patients admitted. Then we've yet to find CMV in a colectomy specimen. We have, some years ago, about to do a colectomy, when they looked at the biopsies again for somebody who had Crohn's colitis, and there the amoebae were crawling out all over the place, which had been missed by the professor of pathology 3 months previously. So, where illnesses are uncommon, you need to get your wits about you and check your bases. She didn't have a colectomy, you gave her metronidazole.
Maybe he had not seen it for some time, that is why he missed it.
Yeah, no, he's now long retired, I hasten to add, yeah.
Okay.
It certainly wasn't Brian Warren.
Another question, I don't know whether you have the answer. FMT. We talk of FMT in relation to inflammatory bowel disease, but have we ever? Do we have any evidence to suggest that FMT has been used and or useful in patients with acute severe ulcerative colitis?
I don't think so, Dr. Ramesh. Very carefully.
But I tell you, if you look at the data published by Dr. Ajit in intestinal research, this is a randomized controlled trial, maybe 30 or 40 patients randomized to FMT on side, and they showed it is beneficial. But that is to talk about the data. Obviously, I would say I will rely on best therapies in acute severe colitis, like rescue therapies, primary therapy, and colectomy.
Okay, a very practical question, and this is to any one of you. We know that now the patient that you presented, very low hemoglobin, very low serum albumin. So I would just like to ask you, intravenous albumin, do you use it, if at all, when? Or if you don't use it, why not? Is it because you're scared that it'll all go into the colon? Second is, when will you go in for a blood transfusion?
You see, I will take up these questions. I would say these are surrogate marker of severity. So if you are getting low albumin, low hemoglobin, high CRP, FDP or fibrin degradation product, low fibrinogen, these are surrogate marker of severe disease. In fact, in a study that we did, which was published probably in 2009 or sometime in Journal of Gastroenterology Hepatology, interestingly, we found those who had FDP positive, those who had low fibrinogen, those who had low platelet count were associated with lack of response to medical therapy and need for surgery. That basically means in that particular patient, actually DIC has set in consumptive coagulopathy as setting, there is a consumption of platelet causing thrombocytopenia. So there is no randomized control trial or any evidence to say that if you give albumin to one group and don't give albumin to another group, is there a difference of outcome? I would say if these are present, then these are marker of severe disease and you have to treat this patient accordingly. Now, yes, in a given patient, suppose a patient has edema, low albumin, and surgeon says wound healing will be poor. Why don't you just give some albumin? This is not scientific, but practical. I have to give some albumin so that surgeon become happy and operate on my patient. Obviously, an exclusive enteral nutrition and other nutritional support is very, very important from day one, because these patients have low albumin, edema, anemia. Correction of those are standard practice. They don't require randomized control trial.
(8:30). There are questions from Dr. Fatmata Mambu from Africa, and from Dr. Anisur Rahman from Bangladesh, from Dr. Sridharan Krishnamurthy. These are all case-related questions, and it would be wonderful to actually discuss them. But individual patients, if you have, we would request you to please ask the question at the website, IBDENC.org. We have a list of top international renowned panelists who will be replying to your day-to-day practice, because I'm getting a lot of questions on individual patients that people have. So over to you, Dr. Ramesh.
Okay, well, I think the final question now, Simon, you said 25 to 40% with the best of rescue therapies. You can probably rescue. If you gaze into the crystal ball, what do you see the future as holding for patients with acute severe ulcerative colitis? Do you think that the newer biologicals would hold any promise as far as better results are concerned? Or do you think that we'll probably continue in this way even with the newer biologicals?
Thank you so much, Dr. Ramesh. So looking into the crystal ball, well, I think it is possible to see some light. And the light is being able to target treatment on the process of inflammation in individual patients. At the moment, the state of the art, which you practice and I practice, is you choose your advanced therapy, whether it's biological or small molecule, just blindly, as though we've got a blindfold on, pinning, as we say, that child's game of pinning the tail on the donkey whilst and we think what might work, and we weigh out the pros and cons, and then we take whatever comes. It's a mad way to choose very expensive therapy. And what we are on the threshold of being able to do, and we just submitted a paper to Nature Medicine just yesterday, actually, is using molecular profiling and transcriptomics to identify the process of inflammation in patients with ulcerative colitis. Now, it's way away, 2-3 years away from being able to scale that up to individual patients, but it has to be the future. And what I mean by that is that at diagnosis, how is that going to impact on acute severe colitis? Well, the turnaround time is not going to be fast enough. But if we can identify those patients at high risk of acute severe colitis in the future, we can look and identify which process, is it TNF driven, is it JAK-STAT driven, is it IL-23 driven, is it integrin driven, or whatever. We can target and select the treatment for that to inhibit that process, and therefore prevent it happening. So my aspiration, and I'll be long retired, is prevention rather than a cure. At the moment, the best cure we've got, and remember we used to use surgical treatment for TB. You know, when you and I are old men, then we might be look back and say, do you remember how we used to operate on ulcerative colitis? Oh God, can't even think of that these days. So let's put Dr. Rao out of business. That's the goal.
Okay, that was interesting. I think a very interesting way to end this meeting. Let me tell you that it is very enjoyable. You should pardon my informality. I've never been one who believes that we should be very formal in the meetings. But I think what we did achieve today was we discussed a lot of things, a lot of issues related to ulcerative colitis, especially acute severe ulcerative colitis. We got enough time, and we could do it at our own pace. At the same time, keep an eye on the watch and see to it that we are not exceeding time as far as the presentations are concerned. So thank you very much, Professor Simon, Dr. Uday Ghoshal, and the panelists. It was wonderful hosting this episode of IBD ENC Masterclass, and I would also like to thank Dr. Jayanti for all her inputs. And she's the mastermind. You know, she keeps saying that this should be done, this should be done, this should not be done. And with these words, back to AIG Hospitals, Dr. Rupa, for the informal closure.
I think without Dr. G. N. Ramesh, and your informality actually adds to the entire program. I think this was very productive, and for future meetings also we'll be looking for inputs for everyone on how to improve. But we thought that this was the first innovative stance, and I can see Nilesh there. Nilesh, all your inputs from different countries next month is yours. So this is the formal invitation, informally given right now. And we would like to have the entire team question and answers. We should answer the load of questions which keep coming, and that can be beyond the scheduled time. And I think in that way everybody gets the gist. PCA and the entire Thailand team, I am particularly thankful because you put together such a nice, crisp video. And in this pandemic, particularly in the current Indian situation, I can't tell you, it was so relaxing. We hope to all be in Thailand one day. We all hope that one day we will have IBD ENC meetings in different parts of the world, in different countries across the region, and we'll take Simon with us.
Perfect.
Thank you so much. Thank you everybody.
Thank you very much.
Muneera, it is Eid for you, but you still joined. Thank you so much. Bye.
Bye, Rupa. Thank you very much indeed.
Bye. Thank you, Master. Thank you.
Bye, Julajat. Bye, bye, bye.